My name is Adnan Siddiqui. I'm a professor of neurosurgery at State University of New York, University at Buffalo. This is a case of delivering a flow diverter through the radial approach. This is a 79-year-old female who initially presented after workup for cognitive decline and was found to have a right-sided posterior communicating artery aneurysm, originally treated with stent-assisted coiling. She also had a left superior hypophyseal artery aneurysm. The patient now presents for that treatment. She has prior history of hypertension, hyperlipidemia, and smoking. She's on atenolol, atorvastatin, aspirin, and Plavix for prior stent placement and for the current procedure. Given the fact the patient had relatively normal anatomy and was bitterly complaining of the femoral closure from last time, we elected to proceed using radial approach. The risks of these procedures remain stroke, hemorrhage, and vessel occlusion. Alternatives include vessel sacrifice and clip ligation as well. We use a 6 French short radial sheath and a 6 French guide catheter, the benchmark. Through that, we use the SIM select catheter to selectively catheterize the vessel over an O3-5 exchange wire. The flow diverter pipeline is delivered over a Synchro 2 wire system through a Phenom 27 microcatheter. Here you can see radial access has been established and an angiogram is performed with road mapping to understand radial loops and other anatomies. It's important to understand these variances so that it allows for successful catheterization. In this case, we saw the wire wanted to go directly into the right common carotid. However, we use a SIM select catheter system to selectively catheterize the left carotid. There you can see the configuration of the SIM select catheter. And once we have it in place, we perform a road map delivering an O3-5 glide wire into the distal cervical internal carotid artery. And with the select catheter still remaining in the arch, we deliver the benchmark all the way up into the distal cervical carotid. And there now you can see multiple intracranial aneurysms in this woman, anterior communicating artery aneurysm, as well as the previously coiled posterior communicating artery aneurysm. A microcatheter is then advanced and brought into the middle cerebral artery, and the microcatheter is then positioned so as to deliver the benchmark guide catheter into the distal cervical internal carotid artery. Once we have this in place, a 5x30 device of pipeline was selected for optimal delivery given the matching proximal distal carotid sizes. And now the device is gradually being opened. You can see there is still distal compression of the device, for which we continue to tug and torque till we have it released. Once we have the device released, then we elect to slowly open the device by pulling and pushing the device. There you can see under high definition microfluoroscopy, you can very clearly see the device is being delivered slowly and progressively, and the device is being manipulated over the microcatheter and wire delivery system to get the optimal obliteration of the aneurysm sac by optimal positioning and wall matching. The Phenom 27 now is brought up all the way into the distal circulation. And again, the flow diverter is pulled back to make sure that we are not jailing the ACA, as well as the fact that if there's any compression of the device or foreshortening, that occurs while the device is being deployed. Final runs here show excellent vessel wall apposition and complete patency of the distal circulation. Important learning points are that with these novel distal guide catheters, these can be brought intracranial to give you optimal support, potentially obviating the need for intermediate catheters. It is also important to note that there are a lot of dynamic movements between different parts when you're deploying a flow diverter. That includes continuing deployment of the device with the microcatheter and manipulating the microcatheter, the intermediate catheter, and the guide catheter to get the device to open, ideally by optimizing vessel wall apposition. The final outcome here was excellent with obliteration of the aneurysm at 1 year.